and you know one fine day that this person is going to land up with a surgery, it's better to give a trial of pharmacotherapy for at least 3 weeks, prepare antibiotics, and then do your CT so that and then also another thing is allergic fungal AFRS. So what are the classical findings, CT findings in the allergic Raghunandan sir?
So we have the mental 2 criteria. So essentially we suspect unilateral problem. The patient comes with significant nasal obstruction, thick allergic mucin, thick serpiginous mucin which comes out, change in smell, parosmia. Obviously, symptoms just suggesting that this patient is most likely developing allergy to fungus. So that is why we call this as allergy fungal sinusitis. Here especially the allergy is to the fungal material which is inspissated within the sinus cavities. So, and obviously in these cases nasal endoscopy will confirm the diagnosis. In addition, we also have the Lanza cavity system for grading the CT scan as well. So we have to correlate both together and decide the surgery.
Exactly. So unless we reduce the fungal load by doing a proper FES, their long-term outcomes are not going to be great. In fact, you're just trying to patch up something with medicines and sprays. Even immunotherapy for that matter, we have to reduce the fungal load and then think of the next intervention. Now coming to counseling, as we know that there are triggers in the environment that trigger the allergies. So as you know, as we grow in our practice, we start seeing first 5 patients, then 10, then 15, and the numbers keep on going. Now about 20 to 30% is allergic rhinitis. So should we spend time, how do we manage doing the counseling bit? Do they work, number one? And if two, then how much time can we give and how do we manage this issue? Because it's just not about writing medicines and sending them. Yes sir, Muthukumar sir, would you like to please enlighten us?
This is one aspect where we should spend time with the patient because proper understanding of the nature of the problem is very, very important. The patient comes shopping from, he goes to several consultants, he says, this consultant is not good. I will go to another consultant who gives a better treatment so that I'm totally getting rid of this problem once for all. So that is the attitude of the patient. He comes there, visits the consultant, he gives a treatment. After this treatment, the disease will go permanently. That is his attitude. So we should impress upon him, this is not a disease. As such, it's a innate nature of the patient. That's a constitutional makeup. So you are having, others are not sensitive, you are sensitive to these other set of conditions. So he should be impressed upon that the disease has remissions and exacerbations. So everybody is manipulating on this natural course of the disease. We are not giving any cure. We are just we are just alleviating the symptoms, hoping for the remission. So if that is impressed upon them. So there's an old saying in the patient, old saying by our elders. So don't go out, come sweating, and then immediately take a glass of water or take a bath. Because our body is warm. When we take a bath or even an ordinary a glass of ordinary water, not even chilled ice water, you are supposed to get rhinitis. So this saying is called a normal individual without allergy. So allergic individuals are more sensitive to difference in temperature. So that should be impressed upon them. So exposure to cold temperatures, the allergic reaction gets initiated. So that is the important thing, and the mental makeup should be changed. And then we should talk about the allergens, the avoidance of the allergens. So this if you impress upon them, and during the exacerbation phase, you should resort to treatment. Then any treatment started, it should be gradually receded. So it should not be stopped abruptly. These are the important counseling advice. I feel it goes a very long way in the management.
So definitely we need to spend adequate time with our patients. If I cannot do it, I need to have an arrangement in place in my setup. So what I do in my routine practice is, we have a counselor who, when the patient comes in, takes a set of questions, and then before they leave the patient, if it's an allergic individual, we generally counsel our patients. There's so many do's and don'ts, whether it's relating to dust mite or pollen grains or pet allergy or mold. So this is available. I mean, there's so many avenues by which all these avoidance measures are present. But if there is a person whom I'm going to plan immunotherapy, those patients I will definitely sit with them and spend sometimes 30 minutes, because this is a 3 years, this is a 5 years commitment that the patient has to give me. So for such patients, I would personally take time off and talk to them about avoidance, talk to them about the long-term outcomes of immunotherapy, about the mechanism of immunotherapy, because the more time you spend with your patient, the more bonding it develops, the more trust it builds. So that is very important. So for immunotherapy patients, yes, I would do it personally, but for every individual, spending 30 minutes, 35 minutes is a challenge. So at least if you're not able to do it, if you're able to do it at a personal level, nothing like it. But if not, have some kind of literature in the clinic or in your setup, or a person who's trained in allergy. In fact, we are trying to train a breed of paramedics, of counselors who know the specialty, who know the do's and don'ts, and who can act as efficient counselors, who can be stationed at the allergy centers or places where the clinical load of allergy is more. Now coming to family, when you're talking to an individual who's got allergic rhinitis, who's got maybe even a bit of wheezing here and there, would you like to talk about the family as well? How is it important? Dr. Raghunandan sir, would you like to?
Yeah, family screening is very important. Nowadays I've made it a point that we grab more history regarding the family environment, etc. Because practically these are people who are living in the same environment. They have a common allergic trigger. Although they may be allergic in different grades, but one or two patients may manifest from the family. That doesn't mean that others don't have the family history. Also, we know that due to the genetic and familial predisposition, the incidence of allergic progression, allergic march, etc. happens more in people who have family-induced allergic prodromes rather than sporadic cases. Literature itself shows nearly more than 100 genes are implicated in familial association of allergy. And these are people who have multisystemic allergy. They may have atopic dermatitis, eczema, bronchial asthma, and even if you treat the allergic rhinitis component, the other components also have to be managed in a multidisciplinary way. So it's important for us to actually prognosticate during the course of treatment, and more so for counseling in future, because other members can be prepared. And finally, these are the patients who will eventually end up with immunotherapy or biologics.
Yeah, so very important. One advantage is it helps you increase your patient base. So you have one patient, now you're talking about the whole family, so you have more patients, more revenue, etc. But like how Dr. Raghunandan sir said, so these family history is important for us because it gauges how the individual is. If he's got a strong family history, he may have the skin lesions in childhood, it may go on to something called as allergy march. Today he may come with a sneezing problem, but 2 years down the lane it may go into a wheezing problem. So these are the people who need to be more cautious. They are more strongly genetically predisposed, more vulnerable. So spend more time in counseling, be a little bit more aggressive in your intervention. So the early, the better. Now if you have a strong family history, you just can't share them and tell them, this is going to be okay, you just go. Talk to them about, the future prospects of immunotherapy, even in the first sitting, because they would have seen their grandfather suffering. They would have seen their father suffering. Now they are here. They are not just here for an inhaler or for a puff. They want a larger answer. They want a bigger solution to your problem. Even if you are not doing it, an immunotherapy, at least brief them or at least sensitize them to these concepts of long-term treatments or immune modulation or something beyond the routine pharmacotherapy. Otherwise, from your center, they just go to other, they just keep hopping around and then they'll turn 40 with inhalers, with puffs and wheezing, and so the immune system becomes more fixed. The earlier you start immunotherapy, the better the outcomes. As the Indian guidelines says, as early as 5 years. So that's the importance of strong taking a family history and phenotyping your patients. Now coming to the pharmacotherapy, which all of us are doing, and there's this debate going about Montelukast, how much to use, how long to give, whether to give or not to give. So Suma madam, would you like to enlighten us about the role of Montelukast?
Montelukast, the current recommendations are against the use of Montelukast as a first-line drug in allergic rhinitis and chronic rhinosinusitis. But it's given as an add-on therapy in patients with asthma. So in a combination of asthma and allergic rhinitis, you can start with intranasal corticosteroids, and if the patient is not responding as you expect, or the intranasal corticosteroid takes some time to have a maximum effect, 2 weeks to 1 month. So in that period, you can cover it up with either antihistamines, oral antihistaminic alone or antihistaminic with Montelukast in patients with asthma. But current guidelines are against use in early as a first-line therapy.
Exactly. Yes. Thank you so much, madam, for enlightening us. Our practice has to change. Even in centers where we generally train or we see even for post-tympanoplasty patients or post-FES patients, no allergy history at all. So they will be needing some amount of antihistamines for a couple of weeks post-surgery, but by default, the postgraduate, he writes a combination of Montelukast with an antihistamine, or probably with a newer molecule, or with a very newer molecule. He gives it, to the patients for 3 weeks. It's a combination medicine even for a post-tympanoplasty patient. So we need to understand that just because a drug is available in the market with a combination, it doesn't mean that we have to keep using it right and left. So the few indications are, yes, very persistent severe allergic rhinitis where we feel that a pure and is taken pure antihistamines, they're not really working well. So you want to add on a montelukast with that. Good, well done. 10 days, 15 days, maybe a couple of weeks. And then after that, usually the sprays will take over. You don't need to prolong it for a long time. Yes, as per the GINA guidelines, if you're talking about the coexisting asthma, even in kids, so there you are justified. In step 2, where you have a coexisting bronchial asthma, there the guidelines mention that yes, for a month or more than a month, you can step up, you can step down, you can give oral montelukast as well.
But I want to add, if you go to any pharma stall outside, all are now selling combination drugs only with montelukast.
Yes,
We had a child who had been on montelukast for nearly 10 years continuously, and he has developed some memory deficits like symptoms. There are lots of neuropsychiatric symptoms, but it is not, we don't know, and the eosinophilic granulomatosis with polyangiitis like symptoms, we don't know whether it's not proved beyond doubt, but it may be because steroids are withdrawn and it may be unmasked. The symptoms may be unmasked because the steroids are not being given, but it is literature has proved that these are all tend to occur in the patient, and that too can occur in a very few days to that treatment may not be very long enough to produce.
So nowadays it's not in market.
So to guide this, I just wanted to add that ENT surgeons should now go into spirometry. So please have one spirometry. It's very simple. Start doing it, and then that gives an evidence-based medicine. You want to add montelukast, please add do a spirometry, and that adds to the.
Yeah, maybe, that's good actually. He's very open-minded. He doesn't mind doing spirometry.
No, you should not tell that you should have a spirometry. You should tell you can't refer the patient to me.
No, sir. This is a scientific conference. Let's be scientific.
Yeah. So, I mean, if you are trained in an allergy, like I've done 1 year whole fellowship in allergy. So, we were trained even in handling atopic dermatitis. I even get now people who come with urticaria, but practicing in a metro city like Bangalore, and you have a dermatologist on your right, you have a pulmonologist on your left, and you have a physician on top, on some of the top in the city. So, it's very difficult if I start seeing urticaria, if I start doing spirometries. So it all depends on the area that you are. If you are in a tier 2 city, if there's no spirometry available, and if you want to do something to benefit your patients, I'm sure, yes, with due training, probably you can start that diagnostic modality in your setup. So it's all about, at the end of the day, the patient should benefit, and whatever we do, it should be with sound scientific knowledge and with a reasonable level of training. I remember Puneet in one of the conferences, because I am into allergy as well as sleep. So he was there, he brought him and he said, what is this? This was initial when we started meeting each other. He said, what is this? You're coming into sleep domain, you're coming into allergy. I'm going to start doing surgeries. So in front of an audience of about 100, close to 100 people, he had asked me this question. So I'm going to start doing now surgeries for the nose in a little bit disturbed manner. And I told him that is okay, you can do a surgery, but you should know how to handle the complications after the surgery. So I still remember telling that to Puneet, and then there was a silence. So that's good. If you're doing a spirometry, then you should know about the interpretation of a spirometry. You should be able to talk to your patient and tell him what the FEV1 stands for, FEV1 by VC stands for. So let's see, maybe in future, as the specialty grows, we will have ENT surgeons who also do spirometry. Thank you, Dr. Puneet, for accommodating
On
that.
that note, if I can just ask Puneet, because now we are talking about related airway diseases.
Yes.
So essentially now we see pulmonologists giving nasal sprays, we are giving bronchodilators.
Yeah.
So don't there should be some kind of a consensus in which we
Yes.
don't over-treat patients.
Yes.
Especially we are having people who are having 2 nasal sprays, 2 bronchodilators, antihistamine, montelukast, everything tried all together. We don't know which is working.
Absolutely correct, Vedanand, what you are saying. Absolutely correct. We should have the boundaries like dura to plura.
Yeah, you should basically, your prescription or my prescription should not be ridiculed as far as evidence goes by my colleague who is a pulmonologist. By looking at the prescription, you can understand the level of knowledge and training that the person has got. So only based on competency, I feel, that we have to venture into the other areas, whether it is inhaled corticosteroids for allergic bronchitis or bronchial asthma, and in the same way for the pulmonologist when he's sometimes even don't look at the previous prescription before giving our prescription. He would have already been on some inhalers in the past, so he'll be continuing that, and then we could add another set of inhalers. So all this, I think, with spending more time with the patient, seeing the previous history, and involving your pulmonologist, you can give better level of care to the patient. So coming to add-on nasal decongestant, I'm sure we still see in a city like Bangalore, we see people coming with nasal drops, using it for 10 years, 15 years, 20 years, the nasal decongestant drops. So I'm sure we all are aware of rhinitis medicamentosa. It shouldn't be used beyond 5 days a week or an SOS basis. I think again that forms a very important part of our counseling, patient counseling. And coming to the add-on therapy, this I want to really discuss this point about probiotics, about vitamin D. Sir, Dr. Gauri Shankar sir, would you like to talk about the role of probiotics and vitamin D?
Yeah. Actually, went through literature, and I myself was of the opinion that probiotics and vitamin D, they don't have any role in managing allergy, but finding it's really shocked to see that the gut microflora has got a relation with the nasal allergy also. So when the gut microflora is depleted, allergic reactions start. They have their own effect on the immunity also. So we have to see that the gut microflora is not depleted, and if there is a deficiency, we have to supplement with probiotics, which definitely some studies have proven that allergic reactions are coming out. Regarding vitamin D also, it is an immune modulator. Vitamin D3 and D2 when given appropriate dose, though not they are deficient of vitamin D, when we give this as a supplement to the allergic patients, there are some sort of beneficial effects are being found out. So what I say is it should be tailor-made for every patient, not as a protocol. For every patient, when they are not doing well, we can supplement with probiotics and vitamin D, which may give benefit to the patients.
Can I add a point?
Yes, sir.
You would have done, you are doing vitamin D for the patients? No.